Hello, I'm Dr. Russel Libby, and I welcome you to the world of medicine. You know, with each pregnancy, the hopes and dreams of our next generation will ride along. And each mother-to-be will expect a healthy pregnancy and a good outcome. But for somewhere close to 600,000 babies, somewhere close to 15% of all newborns, they might come a little bit too early, or they might be born with some kind of medical problem that will require that they receive care in a neonatal intensive care unit, the NICU as we so fondly call it, in the hospital. The NICU is an amazing place. Having worked there as a resident in my training in pediatrics, and then following my patients through the years who might have to go through some period of time there, it's another world in medicine, one that's unparalleled anywhere else in healthcare. It's an exceptional environment where you actually take a baby who's developing as a fetus, who's been delivered to this world too soon, and take that baby to the point where they can live in the world that we know. That can be weeks, it can be months, and in some cases even longer, but it's an amazing process. We're going to talk with families who have babies, who have gone through this process. We're going to learn about the NICU from our specialists. We have a neonatologist, Dr. Robin Baker. He's a neonatologist with Fairfax Neonatal Associates, sorry. He works at Inova Fairfax Hospital. They have a huge nursery there. We're going to hear a little bit about their nursery. We have Dr. Ida Sue Barron. She's a neuropsychologist. She works with these babies as they grow up and helps us understand their developmental outcomes and works with them so that they can get the kinds of services they need if they need it. And as you know, we start by talking to our audience and finding out some things about their lives and their experiences with their pregnancies and their babies in this case. And I know most women go into a pregnancy thinking, this is great. I'm pregnant. I want to have a baby, and it's going to be just perfect.
Completely. That was what I expected, and so my mother told me would happen. I was supposed to have a perfect pregnancy because she did. She had 2 perfect pregnancies and perfect labors, and what happened to me was completely different than that.
At what point did you deliver your baby? How many weeks, or what was the age of your baby at delivery?
My son was born at 26 weeks.
26 weeks.
We started worrying about him when I was 18 weeks gestation, and then I was on bed rest for 2 weeks from the point of 24 weeks at Fairfax Hospital to get me to 26 weeks.
And how much did he weigh?
1 pound, 2 ounces.
1 pound, 2 ounces. That's pretty amazing. Dr. Baker, give us a little perspective on how we judge gestation. I mean, 40 weeks being a term pregnancy.
Right, 40 weeks is term, but I mean, 26 weeks, we consider sort of the limits of viability, where we'll even try to resuscitate an infant at somewhere around 22 to 23 weeks. So this infant being born at 26 weeks in our NICU actually has a pretty good chance of survival and a pretty good chance of having an intact survival, long-term, not having a large amount of long-term neurologic injury. But 26 weeks still is a challenge. Each of these kids are a challenge.
So you say you started the pregnancy, everything was gung-ho, everything was great. Around 18 weeks?
Around 18 weeks I took the AFP test, which in hindsight I wouldn't do again. It's a test that checks for chromosomal abnormalities, and of my faith, I just don't believe in abortion, and so it's not, even if I found something bad, I wouldn't have acted on it. So the AFP test, found out later, has a very high amount of false positives. I think somewhere in the field of 99% of the positives are actually false positives. And I got information that my son might have had Down syndrome. He had a 1 in 121 chance of having Down syndrome. And then, where did that leave me? At 18 weeks with this information, knowing that I wouldn't do anything about it, all it did was really torture me. So from weeks after that, it took me a while to accept to have an amniocentesis done because I knew the risks involved in that as well. And when I had it done, I'm glad I did. It was at the encouragement of the ATC Center at Fairfax because they found out that there was nothing wrong with my son, that the problem was with me. And so that's how they narrowed down that really what was happening was that I had a blood clotting disorder and it was interfering with his nutrition, and that's why he was IUGR, he was on the small side. even then.
And ultimately had to be delivered earlier.
Exactly, exactly.
You started your pregnancy, think everything was fine?
Yes, my first pregnancy. My husband and I had been married about 2 years, and I got pregnant, and then we were very excited, and everything was going along beautifully. At my 20-week ultrasound, my gynecologist, or OB, actually said to me, "You make it look easy." I went on a business trip at 23 weeks pregnant to San Diego, California, and I went into preterm labor in San Diego, and I was on bed rest there for 9 days, and I gave birth to my daughter Elle at 25 weeks to the day in San Diego. And we were there for 5 months.
Home.
No, home is Washington, D.C.
But I bet you know a lot of people in restaurants there now.
Yes, now we do. So my husband and I basically moved out there, and we were there for 145 days in the NICU. We were just discharged on March 17th, and we've been home now about 3 months.
Wow. So it's not even as long as you were there?
No.
All right. That's
No.
amazing. And how big was Elle when she was born?
She was 630 grams, so 1 pound, 6 ounces.
Wow. Okay. That's great. Well, we're glad that you're back east again. Did you have any prenatal testing done that may have...
I had no
Been
prenatal testing done. My son was conceived through IVF because I had a history of fertility issues. At 2 weeks, they test you to find out whether you're pregnant when you do IVF. Before the 2 weeks even came, I started to have bleeding issues, and I was told placenta previa, disappearing twin, and it came and went. At 12 weeks, I was put on bed rest. I have lost track of the number of times we were in the labor and delivery ward to stop contractions very early on. At 22 weeks, I had I passed a big clot, went to the high-risk doctor, got sent home, told that my uterus was extremely hard, and I had a cervical polyp. And then at 24 weeks, I went back in for my checkup, and I was in labor. And the previous night, I was actually in the hospital to stop the contractions that I was having. And I was admitted to Loudoun Hospital, and having the knowledge that I know Fairfax was a much better NICU than the Loudoun Hospital was at the time, I got transferred to Fairfax, where I made it for 2 weeks, and he was born at 26 weeks.
Wow. Well, we're going to hear a little bit about bed rest. Doesn't sound very relaxing. And your baby, how far along was your baby when...
She was 26 weeks as well.
26 weeks. And how big was she when she was born?
1 pound, 14 ounces.
All right. And did you have any pre-knowledge that there was going to be a problem?
I had absolutely no knowledge. I had what I view as a perfect pregnancy. There was no nausea. There was no... I felt great. And... you know, I remember my OB saying, "Oh, you're going to have a baby, I predict, that will weigh between 7 and 10 pounds. And at first I was like, of course I am. And then, you know, she came out, of course, 1 pound, 14 ounces. But basically it came very quickly. I had a placental abruption, and within 2 hours she was born.
So, do you remember any of that? Not much. But it was a good time, I guess, huh? Well, we're certainly glad you're here. I'm glad you could come and join us. You had a healthy pregnancy?
Healthy pregnancy. In fact, further along than most women here. I was at almost 35 weeks when I was admitted to Fairfax. And I went over on my lunch hour for my checkup and was told that my protein levels were high and that I was being admitted to the hospital, having no idea what that meant. And a couple of days later, our son was born, 4 pounds, 2 ounces. I had HELLP syndrome, and he spent his first 5 weeks at the NICU.
Well, we're going to hear some more, but it sounds like some people get prenatal testing. Sometimes it's indicative of something, but it sounds like most really don't have any idea they're going
it's absolutely correct.
to deliver early.
You know, most of these women, as noted by they really don't have any idea when they start down the road of pregnancy, and this sort of comes out of left field. And they're not prepared, and I think most people, until they have a premature baby, don't even know neonatal intensive care units exist. I mean, when I'm in the community and I tell people what I do, they sort of look at me and say, "Wow, I mean, that's interesting. You know, how do you say that again?" You know, so it really is a whole new venture. I mean, in the early 1960s, neonatal intensive care units didn't even exist, and it's only recently have we been able to have the technology develop that we can begin to take care of these infants.
And we're going to hear more about some of that and some of the outcomes. How well developed is your baby at the time of birth?
He was 32 weeks.
32 weeks, so that's pretty good,
Yes.
you thought. Relative to
Yeah.
what you came to understand was in the NICU at 26 and 25 and 24 weeks.
Yeah, in fact, I thought he looked big compared to some of the other babies
It
in
was,
the NICU.
yes. And you had a relatively healthy pregnancy up to that time as well.
I had a relatively healthy pregnancy up until about 23 weeks when I had my first preterm labor scare.
Right?
Been up to labor and delivery, had the contraction stopped several times, was on medication. And then at 30 weeks, went up for a preterm labor scare, and they found that my blood pressure was high, and then I was admitted to the high-risk unit for preeclampsia.
And you were there for how long?
I was there for about a week and a half before he was delivered.
Wow. And you?
Well, I had 2 healthy pregnancies, full term, and then with my 3rd pregnancy, everything was going fine, and then I went in just for a regular checkup, and they told me I was spilling 4+ protein, and my blood pressure was through the roof, so I went right over to the antenatal testing clinic there at Fairfax, and ended up in HRP for about 4 weeks before they had to go ahead and deliver him at 26 weeks. And he was IUGR as well, so he was about the size of a 23-weeker, so 1 pound 10 ounces.
Wow. Pretty amazing. So you've had 2 healthy babies, and
Yes.
that's the way it should go. It is a shock. What's bed rest all about? Is there such a thing as really resting when you're
Yes, there is.
worried about delivering a baby?
Yeah, there is. I mean, bed rest actually is one of the few things that probably does help to some capacity in the mom that's in preterm labor. But it is just you're in bed 24/7. Sometimes you get bathroom breaks.
Yeah.
I don't know how many.
fuss at me if it was over 2 minutes.
There it was, yeah. So, but it is used for moms in preterm labor.
Right. And you have a baby with you here today.
Yes, this is Russell.
Yeah?
He was born at 25 weeks, 1 pound 5 ounces at Fairfax Hospital in their NICU unit. My story is, one, I didn't know I was pregnant. Then when I found out I was pregnant, I was already 3 months along, and everything was going fine. Just had something feeling funny other than baby kicks, and went to my doctor, and he said I was 3 centimeters dilated and told me to go straight to Fairfax. I was there for 5 days and delivered him on St. Patrick's Day.
Wow.
So no sign whatsoever, first pregnancy, scared to death, and he's doing fine now.
So you were in the delivery room, and you knew you were going to deliver a baby early. What was it like being there? I mean, was it something that you had ever imagined? Were you scared? Were you
I was
relieved?
scared. In all the books that I was reading, it didn't mention anything about a NICU. I laughed with the nurses because I said, I've only read up to 25 weeks. I don't know what's supposed to happen next. So they helped me along, and the nurses and Fairfax Hospital were great to help teach me how to care for him, and as well in the hospital as well as when we came home. But just my pregnancy itself, I just had no signs, and next thing I know, I'm in the NICU unit, and I'm like, what's going on? And
when you went to the NICU, or when your baby went to the NICU, I guess you were in the delivery room. You had some anticipation. Were you familiarized with what happens before you delivered?
No, I did have a few weeks in HRP to kind of have the idea that he might, but I was kind of in denial. I was like, no, I'm going to be here for the next 4 months until he's born. I'm not going to have this baby early. So, so when he was delivered early, it was something that we had to deal with at that time. And I work at the hospital, so I have a little bit of familiarity. I'd been in the NICU before, not as a parent, not as a family member, so it was completely different. And it's amazing. I mean, they're so tiny and so fragile, and there's so many of them there that are struggling.
Yeah, tell us a little bit about the NICU at Fairfax. It's really one of the national centers that's recognized as a really very high-level NICU.
It is. Inova Fairfax Hospital delivers about 13,000 babies a year, which is in the top 5 in the nation. The neonatal intensive care unit at any point in time may have 75 to 80. I think today we had 84 to 85 babies in the NICU. And they can range anywhere from term infants that may have heart disease, may have gastrointestinal problems, infections, all the way down to the micro-preemies at 23 weeks or so. So, you know, the major percentage of the kids actually are the bigger kids, you know, are the 30-week or greater that do have some sort of, again, heart disease, gastrointestinal disease, infection. But it is these subsegment of kids, these smaller kids, that really get the bulk of your attention and take most of the resources of the NICU to continue to run. So it's a wide gamut, lots of babies, and a very active, busy place.
And I know that we have really a rather famous baby over here. It's not really a baby anymore. But do you know anything about your birth?
I know that I was born 26 weeks early.
And do you remember how big you were?
13 ounces.
13 ounces. That doesn't make a pound. No, it's amazing. And what happened with you with your pregnancy? How did it evolve? Tell us.
I also had the prenatal testing and ended up having an amniocentesis. I had also decided that I wasn't going to terminate, but I still wanted to know. And it turns out that in my 24-week checkup, I was told I had high blood pressure and that she stopped growing at 21 weeks. So I knew she was small. I went on bed rest. I did go on bed rest. And a couple days later, I had a little back pain, ended up in the ER, and the next thing I know, they told me that she had to be born. They were very secretive. I found out later that I had ascites, with very rare fluid on the stomach, and my liver was about to rupture. So she had to be born. I fought all the way, just like she fought.
She had to fight, I'll have to say.
But I finally gave in. They finally, she was delivered by C-section, and the rest is history.
So you were really very, very sick.
Very sick. Mm-hmm.
So at delivery, you had an epidural. You were awake for the delivery?
I was awake. They told me that the only way I would let them do an epidural is if they agreed to let my wonderful husband come into the delivery room with me, and they said if I could stay awake, he could watch. So I was able to stay awake. He was able to watch. But as soon as she was born, he zipped off to the NICU, so I was by myself.
Had you ever seen a baby being born before?
No, this was the first time. It was kind of a unique experience.
I would imagine. Your heart was probably in your hands and would have been bigger than she is or was at that time.
Well, you know, actually I was pretty excited.
Yeah.
You know, I saw and heard the stereotypes of the males collapsing in the delivery room, but you know, being in the military, you know, that background kind of gave me some sort of fortification to stand on the ground, and
kept you propped up anyway.
It sure did.
Yeah. Well, and they took that baby right from the delivery suite.
Well, she had to fight. She had to fight for 2 minutes to live,
Right.
and as long as she fought, then they.
Okay, so she was young enough so that you had to actually check her viability.
Oh, absolutely. You know, she is born smaller than the criteria for resuscitation. Usually infants less than 23 weeks and less than 500 grams are not aggressively resuscitated because a long-term neurologic injury, long-term neurologic outcome is very abysmally bad. So, but she presents an interesting situation to where we know she's 26 weeks, but yet she's smaller than what we would typically resuscitate. And yes, it took us a while to sort of get her going. Mom had pregnancy-induced hypertension, which means the vessels going to feed Alexis were decreasing in size, so the baby was not going to grow. I mean, it was a life or death situation actually for Mom to deliver. And being born very small, I mean, she really is an incredible story that she's with us today, as all these infants really are.
So when these babies are delivered, and of course you were there in attendance,
right.
and the first thing you assess that the viability, more or less, if they're that small.
Right.
But, you know, let's say they're 26, 28 weeks. Initially, you observe them. I mean, are there ways that they can help these babies be ready to be born?
Well, we have a fantastic obstetrical group, maternal fetal medicine group, and they monitor these infants in utero extremely well. And really, when they say, you know what, the baby is not doing well, it's time to deliver, then they deliver. So it's really unusual for us to get a baby who is in terrible shape at delivery, because the maternal fetal medicine and the obstetricians do such a great job. Usually those are, I think we had a parent that had an abruption. Those kids can be born really very, very sick, because there's a lot of hemorrhaging before the baby's born, and the infant is very anemic at the delivery. But Alexa's had a great treatment and observation in utero, and we also probably gave her some betamethasone that helps the lungs to mature, and we assess the viability, but we assess the infant at delivery, and the heart rate and their color and their movement, and then you give them all a fighting chance, you know, and lo and behold, if I remember correctly, you know, it didn't take a lot to get her going. I mean, you know, you just give her an airway and boom, she's just kicking. And
you know, we do have pictures of her in those first hours, and as you can see, she's pretty small.
Well,
you see the big pen right next to her, and it's not from the giant store, I promise.
No, no.
And we have another picture, and you can describe what's there.
She was a solid 360 grams at delivery. And the ET tube that you see is the same as that we have here on the desk. It's the smallest that we have, obviously. And
the other thing, go back to that picture one more time, if we could, and you can see on her arm.
Yes, there's a ring. Her mother's ring is on her left arm, which is going all the way up her arm. And the reason her skin is really glistening is because we coat them right away with a medication called Aquaphor, and it keeps the fluid in. Otherwise, the skin is so thin, as soon as they're born, their insensible water loss just goes extremely high. So the Aquaphor keeps the fluid in and makes it manageable for us to take care of these kids.
So babies need oxygen, obviously. That's a big deal. Your baby was on a ventilator
for 8 weeks. I couldn't hold him for the first 2 months of his life, and like Alexa, my son was 499 grams, so he was
pretty small.
And I also, things you forget, I also had pregnancy-induced hypertension, so there were two things affecting my pregnancy. But yeah, it was a long road, and then after he was weaned off successfully, because I think they attempted once before during that 8 weeks to the CPAP, then it was a very slow wean to the high-flow nasal cannula. The unblended and the blended nasal cannula. So it was a long time. And he even came home on oxygen. He was on oxygen for 6 months. After that, 3 of the 6 months he was on it 24/7, and then they weaned him to just at night. But it was a very slow process. And he's 2 now. He'll be 2 tomorrow. And it's just amazing that it feels like that happened to somebody else. It doesn't feel like it happened to me.
And I'm glad that that's the way you feel. So it seems like the lungs are really the last bastion of development that dictate, I guess, maturity.
That's correct. Right.
So at what age are most babies physically able to breathe and exchange air without having artificial ventilation or extra oxygen?
Without having support?
Yeah.
Well, it really varies, because again, if you have, a lot of these babies are small for gestational age, and if you stress a fetus, they seem to mature a little bit faster. It's not uncommon for us to have an infant born at 27 or 28 weeks that only needs minimal respiratory support during the initial hours and weeks. And on the flip side of that, you may have an infant of a diabetic mother, and we know that can cause the surfactant to mature slowly. And an infant born at 37 or 38 weeks, it still may need respiratory support. But usually the smaller kids are the ones that are going to need the bulk of that support, and the bigger ones probably won't.
Okay. And what is the one thing, the intervention you remember the most significantly that happened with Elle when she was just a little tot?
Well, her biggest thing were her lungs. We were very fortunate when she was born that she didn't have an IVH, a brain bleed, but she was ventilated right away, and she actually was on the ventilator for 7 weeks. They tried to extubate her twice. She actually extubated herself twice. She's a fighter, and but that was the biggest thing for me. Once she was off that ventilator and on CPAP, and I could really hold her and bathe her, I felt like a mother for the first time. But that was our biggest thing, I think, were her lungs, and still are. She actually is home on oxygen right now.
And your grandma.
Yes, I'm grandma.
And when was the first time you were able to hold your grandbaby?
Wasn't Thanksgiving, so it was sometime
January.
She
was about 3 months old.
I got to go hold her.
I bet that was quite a thrill.
It was, because before that we'd seen her in the isolette, and just everything, tubes everywhere, and then I finally got to hold her.
In San Diego.
In San Diego. Yes.
It's always an amazing thing. And what do you remember most significantly about the time that you had in those first few weeks in the NICU?
Most significantly, Nicholas kind of did the typical roller coaster ride of a preemie. He was born on the oscillator for a few days, went right to CPAP, was doing really well. There are actually 3 significant events that I remember. First one was he had to get a central line because his umbilical lines dried up, and it was placed and it migrated to a smaller blood vessel. His lungs collapsed because the fluid that was going in the central line went into his chest cavity. We got a call. We had to go, and when we got there, he was on a ventilator. And when he was first born, I didn't get to see him right away. The first day I saw him, he was not on a ventilator on. He was a CPAP, and I had not yet seen him on a ventilator. And it was very, very emotional for me, as you can tell. And then when he was there, one of the things that I remember is he did have an eye exam. They get ROP, retinopathy of prematurity. And it was the day before I was supposed to go back to work, because I went to work while he was in the NICU in the latter part. And he just pooped out after his eye exam, and he had to be his oxygen support had to be boosted, and it was a really hard day for me and for him. And then his last significant event happened when he was in the feeder and grower room. Somehow he got RSV, and he fared very well. He did an amazing job. But when you're in the NICU, they talk all about germs, and it's the first year I had ever gotten a flu shot, because it was instilled in me how vitally important that was. Actually, your office gave it to me, and I couldn't find it anywhere. It was the year there was none.
Oh yeah, the year the flu vaccine, sure.
And so I did everything that I could to keep him healthy, and he got RSV, and it scared us to death, because it had been explained to us what RSV was, and until you go through that, you don't realize it. And so when he did come home, we were probably, I think, a little hypersensitive. Nobody was allowed to hold him. We did not take him anywhere. We were very conservative the first few months that he was home. He's very healthy now, though.
So, Dr. Baker, we have a significant amount of reserve in our lungs. We maybe use 25% of our lung capacity in a daily routine. If we're exercising, 75% in heavy aerobics, but there's still lots left. These babies don't have much reserve. In fact, you have to give them oxygen. Is it because there's not lung tissue that's there, or is it because of other factors?
It's other factors. It's the maturation of the lungs. The lungs in us have a very, very thin membrane which separates the blood and the oxygen. In newborns, that membrane is much thicker. And so the concentration of inhaled oxygen has to increase to go by passive diffusion across into the bloodstream. As you get older, that membrane thins, as it does for us, so you can exist on the room air. But yes, there are maturation and differences in their lungs and ours. But they really live on every little piece of lung they've got, so that an infection, even though it may be minor for some of these infants, really is a huge challenge for them, because the sheer fact they need oxygen when they go home means they're using all they can. They need that extra little push. And again, once they get sick, it can really be quite devastating for them.
Wow. And you had a baby that was a little bit older than some that we've been talking about, but had to go to the NICU. Mm-hmm. What was the story? What happened there?
He had a VSD, still has a VSD, and he basically was too tired to eat, too tired to do anything, and at 4 pounds 2 ounces, he could only not even eat 2 cc's. It was a challenge, and I didn't get to see him for the first 48 hours of his life, and I can remember my first time visiting the NICU and hearing the NICU nurses referring to the babies as my baby. And as a new mother of a first baby, I can remember the first time I heard it and thought I was going to cry, and it wasn't until the following 5 weeks of visiting the NICU and basically living in the NICU that you so appreciated nurses that referred to your baby as my baby, because when you did go home for those few hours of sleep, you knew that the baby was going to be taken care of as if you were there.
So that must have taken your breath away. I mean, that really would. Here you've gone through a pregnancy, you've had an incredibly difficult delivery and moment in your life, really on the brink, just with the process that was going on for you, and here's a baby who's going to the NICU, and somebody's taken possession of them.
My baby.
Now, the NICU does an exceptional job of taking care of babies.
I can't say enough about the NICUs. Well, for us, it was Fairfax NICU. I was diagnosed with, I was found out early in my pregnancy I was having identical twins, which was a surprise. And at 18 weeks in the testing unit of Fairfax Hospital, we were diagnosed with a rare condition called twin-to-twin transfusion syndrome, which affects about 1% of identical twins, which identical twins are rare as it is. My babies, I was on bed rest from that point on, and my babies were born at only 24 weeks. They weighed 1 pound 1 ounce and 1 pound 5. And we were advised on several occasions, first to terminate the pregnancy, which our faith would not allow us to do, and then to not resuscitate our babies. But after the docs came to the position that the babies were rallying, and so we'd rally behind them. As long as the babies rallied, we'd rally. And I can't tell you how incredible the care is, at least at Fairfax. Our babies went through 2 heart surgeries for PDA ligations. They had retinopathy of prematurity surgeries. They were on ventilators for 9 weeks. They had full renal failure. They had just about every prematurity-related condition you can have, and they are walking, talking, happy preschoolers right now. And I have a picture, I don't know if the camera can pick up, but this is, I mean, you can see how tiny a 1 pound baby is based on this footprint. And this hat covered one of my twins' eyes, and we had to roll it about 3 times. But they're chubby and happy and cognitively doing great. And some of that is, I like to say, my genetics. Some of it's God, and some of it is excellent medical care. So.
And it is really amazing. I know that the ventilators now have evolved, and when people are called upon to donate for equipment, and I know you're involved in raising funds for.
I have been
for the NICU.
For several years.
Yeah, and I know that
it's very rewarding. It's probably the most rewarding thing you can do.
Because you get ventilators, you get equipment that can save these babies, and you see them here. And they're very specialized pieces of equipment. As I said, having worked in all different areas of the hospital, there's nothing that compares to the technology and the sophistication of what you do there. The nutrition, we're talking a little bit about how babies get their nourishment. You were saying 2 cc's of, obviously you can't survive very long. That's less than a half a teaspoon, and babies need more than that. Were you able to feed anytime soon after the delivery of your baby?
No, and I can't even remember when we were able to first feed her. But right away, the lactation consultants were in my room and encouraging to pump breast milk, because that is very important for premature infants, and it's actually very different than the breast milk of a full-term infant, and it has some very special properties to it. And so I pumped all along her NICU stay, and I continued to do that for a great while after that as well, because I knew that was the best thing for her.
So at what age was she when she had her first sip of milk, so to speak?
I want to say 32 weeks.
Probably close.
Yeah.
You know, the suck, swallow, breathe coordination to feed really develops somewhere around 31, 32 weeks. So the fact that we'll give them a bottle at about that time makes sense. They'll sit there and suck on a pacifier. But every one of you in this room watched your child at 26 weeks just sit there and go to town on a pacifier. It doesn't mean they know how to eat, though. They just know how to suck.
All right.
And it's called non-nutritive sucking. It's actually very therapeutic for the infant. It's calming for them, and it really helps them quite a bit to like I say, calm down. But formula would probably not be introduced orally until about 32 weeks or so.
And really, that's the whole process that we assume babies are doing in utero with their hands.
Exactly.
Using them as pacifiers and learning how to suck and to coordinating those muscles and to ultimately, I guess, in that last trimester, start to swallow the amniotic fluid that they're sucking around their hands on.
No question. It's not uncommon to see a baby born with blisters on their wrists, sucking blisters from in utero. Yeah. Same one.
That is pretty incredible. And your baby was how many weeks ago?
She was ultimately born at 35 weeks.
35
so
weeks.
I was in that group that is actually the most common group of preterm infants, which is the late preterm infant. However, my water broke at 29 weeks, so I spent 6 weeks in the antepartum unit, hoping that I wouldn't continue on into labor, and they did the betabethazone, and but she's still, even at 35 weeks, we thought we were in the clear, that she would go home with us, and she needed to spend 2 weeks in the NICU and was on a ventilator when she was born.
And we have a picture of her on a ventilator.
And can you imagine how big she was?
If we can get that picture of the ventilator baby. Well, it'll come up when it does. I'll let you know.
She was 6 pounds 6 ounces at 35 weeks.
It's a big baby.
They honestly, she was huge in the NICU.
Okay, good.
But she was really sick.
Yeah.
They talked about medevacing her for ECMO to another hospital. She had a really tenuous first couple days. But since she was far along, she got better fast, which was a blessing for us. And she's 5 years old today and doing well.
Great. It's amazing. And I know that you've been involved in the neonatology efforts as well in terms of supporting parents as they go through this. Did you get some support from some people out in the community when you were going through this?
Yes. Besides my husband, my parents, friends and family, the nurse staff at Fairfax, our support group leader, her name was Lynn. That was probably the greatest thing for us, Lynn in the NIC unit. Just someone to talk to. Any concerns we had just with his growth, just anything.
Babies get infections in the NICU. Did he have any infections?
No.
No. So you were really fortunate.
Really fortunate, and some of our neighbors did get infections, but I would have to say the hand washing and just taking every precaution really helped us.
I'd say it was a pretty good run of luck too.
Yeah, the people in the hospital were just great, and then we tried to keep our hands clean and follow all the instructions that we got, and he didn't get any infections.
Well, he looks great. Absolutely looks fantastic. Infections have got to be the most dangerous and worrisome part of taking care of these babies.
Yeah, no question. We've actually studied this in detail at Inova Fairfax Hospital with children. We've been able to decrease it significantly, but any infant that gets an infection, their hospital stay is typically about 10 to 14 days longer secondary to the infection. So our ability to study this, to have explicit hand washing as all the parents do. We put in central lines under very sterile conditions. We change the lines appropriately. It's really decreased this infection rate, so we've been very pleased with that aspect. But yes, they can be extremely devastating to the newborn.
You went through some ups and downs that way?
Yes, we did. Well, we had we had actually 3 courses of the Decadron steroid to help his lungs, and that, my understanding is that really reduces the immunity. And so unfortunately he got an infection in his lungs with the first course of Decadron. So he actually got fairly septic and had to have all kinds of different antibiotic treatments. He had they called it a cocktail of 5 different antibiotics that he was
all
on
going at
for,
once.
Right,
Wow.
for several weeks. So that was one of the reasons he was vented for 2 months, and it was 2 months before we were able to hold him as well. But that was very hard, but it was because he was fighting that infection.
Right. And it's amazing, knowing how these babies are physiologically developed or undeveloped, let's say, when you manage their fluids and you're talking about amounts of salt in their fluids that are like a fraction of a granule of salt, and that if you put too much in, they can't breathe that day. Tell us a little bit about how you all do approach the whole nutritional perspective and what happens with babies.
Nutrition has made the survival of the micro-preemie possible. I mean, really, because we've got fantastic total peripheral nutrition packages now where I can give them all of the carbohydrates they need, I can give them the fats they need, the lipids they need. I chronically monitor all the different electrolytes in their blood and adjust that. We can pretty much do that every 12 to 24 hours. But it has continued to be researched and looked at what the preemie needs to grow. And what we try to do really is mimic what they're getting in utero, so that we're trying to give that same amount of, again, fats and lipids and carbohydrates and salt and potassium and whatever it is into the total peripheral nutrition and feed it in. And really the micro pumps, or the pumps that can deliver 0.1 to 0.2 cc's an hour, have made it possible for the small infants to survive. Because if you take an infant that's 400 grams and you realize they may only need 60 to 70 cc's over 24 hours, I mean, and in that you've got to give them all this nutrition through many, many multiple different lines. It really is a challenge. But nutrition has been one of the huge advances that, again, has led to the survival and the intact survival, I think, of these infants.
So, and babies end up on what they call TPN.
Yeah, actually, my Nicholas was on a TPN, I guess 3 different times, because he had some, different feeding issues. He had NAC, or what they thought was NAC with no surgery. It resolved itself. And he actually had his gallbladder removed last month because of gallstones that he got from the TPN lines. So that was something that's kind of a post-NICU experience. But yeah, he was born 24 weeks, and he's thriving.
Looking great.
Yeah.
Shows you don't need that gallbladder anyway.
That's right. Right.
And surgery in those babies. Now, I know that the history for many of these are actually having open heart procedures when they're less than 2 pounds. Right. How do they do surgery on kids that size?
Well, most of these infants probably also have what's called a patent ductus arteriosus, and we actually do that at the bedside. Now, I don't know about 5, 6, 7 years ago, but now we do it right at the bedside. We have an anesthesia team that comes up, because the kids will get cold stressed if I start moving them around. So we'll break open the isolette, the surgeon will come in, the anesthesiologist will take over, the kid's asleep, the heart surgery's done in 15 to 30 minutes, closed and gone. So the minor stuff is really done at the bedside. We try not to do significant heart surgery on a very small baby because it's technically very, very difficult to do. So we try our best to give them nutrition to get them to grow, to get them to be of a much bigger size. So really significant cardiovascular surgery in a small infant is very, very difficult to do.
Your baby had a heart problem, and that's what seemed to take him to the NICU in the first place. Mm-hmm. Did he have surgery?
Well, the first week they thought they would have to have surgery. I looked at my notes the other day, and I had a note that said, Lee's going to have surgery. Well, fortunately, he didn't have to have it.
He didn't.
He's never had it.
All right.
He sees a cardiologist every 6 months. Everything's going well, and he's a gift.
Yeah.
He's doing great.
That's great. So he avoided it. He was lucky.
He did.
What do you think the most dangerous thing for your baby in the NICU in terms of what can happen to them as preemies?
Well, for our baby, who is a little bit older, the thing that I think scared us the most, and based on conversations with the nurses, was RSV. It was the middle of the winter, and we were basically petrified of him catching RSV, even after he came home.
Right. So, and RSV is a really common viral infection that will infect somewhere close to 70% of all children in the first year of life. And unfortunately, you don't get it once, you can get it multiple times, and many will have a second episode in their second year of life, or sometimes even twice in the first year. It's extremely contagious. And I know that you were telling us that your son got RSV. And what happened then? There you were in the comfort and security of your NICU, and you've been describing how it's one-on-one nursing, my baby, how everything works in a great way that you feel very secure when you're not there.
And you kind of just nailed it on the head. When you have a child in the NICU, the nurses have done such a wonderful job, and the doctors have done such a wonderful job building your confidence in their ability to take care of your child. And then they go through something like that, and they transferred him to the PICU because at the time there were other babies who were much smaller than him, who RSV was such a risk to their life that he couldn't be there. It was better for him and the other children to be in the PICU, and the PICU operates very differently than the NICU. And in hindsight, we were not there all the time at the PICU because they encouraged us to go home. In hindsight, had this ever happened again, I think we would spend a lot more time. We were kind of still on the NICU path. The PICU took very good care of him, but it was a very different kind of care. The parents had to be much more involved. You truly had to be your child's advocate when they are in the PICU. As you do when you're in the NICU, it's just a different process. And it was a very scary experience having him taken from this comfort zone, not just for him, but you know, I mean, we had nurses with Nicholas that we would call up and they knew that we wanted to know where his oxygen was, how much he weighed, how much weight he had gained, whether he had stoled or not that day, because it's a big issue for little guys to go to the bathroom, you know, and, you know, we had nurses who knew us, and they knew that we were the uptight, controlling kind of parents who wanted to know every little thing about their child. And you go to the PICU and you get a call in for a status. He's doing really well. And I'm like, okay, but the rest, you know, and so there's that yank of a comfort zone. And then you also have to go from relying on your intensivist to your pediatrician to your pulmonologist to the other doctors who you may or may have not forged a relationship with. And you have to depend on a whole new group of people and an environment that you are very unfamiliar with, and it was very difficult.
Those transitions, they were really thrust upon you, and you were not prepared.
Not at all. Not at all.
How do you prepare parents to be able to deal with taking a baby home from a place where that kind of care takes place?
Right. You know, we're very fortunate that March of Dimes is partnered with Inova Fairfax Hospital for Children. It has now a parent support group, and very early on, right after the kid's admitted, they meet the parents, they give them a camera, they start making scrapbooks. I mean, we really try to start to forge the bond between the mom and the infant again, realizing it's extremely important to do that early, and that really sets the tone, I think, for the whole hospitalization and helps them get ready for going home. I think what most of them feel, though, is it's a roller coaster they have no control over. I mean, here it is, they've got a child, and they can't make any decisions. They don't feel like, you know, they're in there, these things are going on, and they're completely out of their control. We live in a world we can control just about everything we do, and we get information right away, and all of a sudden, there's no control, and the physician is saying, we don't know. I mean, it's just hard to comprehend a lot of times. It's such a change. Why we can't, you know more and tell them more in the 21st century, but again, it's
I think it's
medicine.
pretty amazing that you can take a baby that's less than a pound and take them as far as you do. All right, now we've given you the break thus far, but we want to know how you look at these things. You are the neuropsychologist, you see these babies, you see these families. You probably take them all into consideration as you sort of get your impressions as to what's going on, what they need. Babies are born at 24 weeks. Where are they developmentally, and what do we see routinely as they grow from there?
Sure. Well, first let me say how wonderful it is of all of you to share these stories that you've been sharing. It's very impressive, and it's a real testament to resilience. It's not only your baby's resilience, but it's the resilience of you as parents. It's a remarkable episode of things that you have had to go through, things you have learned. Just your vocabulary, I think, exceeds mine. And I am a neuropsychologist, which means that I'm interested in how what happens to us and what happens to your baby affects the brain and therefore affects the behavior, and how are these babies going to turn out, because the babies are exposed to such an array of conditions. And so we've been doing research, thanks to the generosity of the NICU letting us in to do that, and looking at the outcomes of your really tiny babies. And I must say, and I've also just reviewed the literature for 3 years, 4 decades of literature, of realizing that there are so many different impacts of what has happened, and it's not all the medical factors. There's very strong family factors. There's very strong social, environmental factors. Physician attitude is well recognized in the literature as extremely important, one of the huge advantages, I think, of the Fairfax NICU. And so what we're learning is that there's great optimism for babies. I have seen babies as young and as small as some of yours whose, our studies are showing that they're of average intelligence, even down to 23 weeks. What we're not saying is that they're perfect, because none of us are really perfect, and these babies have come through a lot. But what we're seeing is it's like the level is raised, the bar has been raised a bit, and whereas 30 years ago we didn't have great expectations for their cognitive outcomes, now we're seeing that they can do really well, they can go to school, they may need some special education help, they may have some neuromotor delays, which would be one of the most common things to see. But they have much less in the way of blindness and hearing problems. Their IQs have risen. Their ability to function in other ways, their memory, their language, their social environmental, the social emotional factors, these have all really improved as a result of the medical advances that you have been exposed to. So it's really a remarkable trajectory of change for your babies who were born in these recent years, as opposed to what I read about happened 3 decades ago, which we would have heard far worse and terrible stories. So it's really a very exciting project that we've been involved with to see these outcomes, because we kind of believe that given the right early input and the stimulation, that we can really help these children do very well. Maybe there'll be a little problem here or there, and even those babies who have come through really significant medical problems, for reasons we don't really always understand, can do well. And then others who don't seem to have that many problems may not do quite as well. So there's a lot to be learned. But it's very exciting, and it's very overwhelming to know that you have been able to take it to those steps and really understand your babies. That's a huge step.
You have twins. And your twins, did they go through a similar hospitalization course, or?
They did not, and it's interesting being the parent of twins, because when they're initially born, and mine are at 24 weeks, very critically ill, they put them in whatever bed they can find. We don't have the luxury of putting them in cute little isolates next to each other. So when they were initially admitted, I had one in room 4 and one in room 1 or room 2. And there were days where they were having different critical episodes, and I was literally, my husband and I were running back and forth, bedside to bedside, trying to figure out which twin needed us the most. So the one in renal failure got attention that day. There were days when I wouldn't see the healthier twin for hours at a time. Eventually they ended up in the same room together. But I think what was fascinating for us is when you have a baby born that early, as you mentioned when you did the introduction, they're developing, the fetus is developing in front of you. So you switch between being a mother just grieving for your baby that you can't hold, and also being fascinated. I mean, they're born with their eyes fused shut. You can see through their skin. They don't have fingernails. And so sometimes you're just wondering, I remember asking my nurse, will their eyes open? And she laughed and said, of course they open. But you don't know this because you're delivering a fetus with its eyes closed. But yes, that was very tough, because you try not to compare, because no child has the same course, but they're identical twins, and you have an image of twins sort of developing the same way. And even now they have different issues. One has gross motor, one has bad lungs, but they're amazing. Yeah. They're miracles.
Developmentally, when you have a baby who, let's say, is born at 26 weeks, when they hit term, are they acting like a term baby? At 40 weeks, are they acting just like a baby who would just be born today, or have they integrated certain social or motor skills that are ahead of that time, or do they continue to lag behind those who would have been born at the same time? We
have to make allowance for the fact that they came out early, and so they do lag behind, and we account for that. We call it a corrected age. And in order to really, for example, the baby who's born at 23 weeks, the gyri on the brain, those lines that you see when you see a picture of the brain, they're not even there yet. The brain has not begun to develop. So that developmental context is central to everything we need to know about a baby. And so it's just that course of development is going to take the baby longer. So we have a great allowance. In fact, up to age about 3 years of age, we usually use a corrected age, which means we've deducted the number of weeks they came early from their actual age. And so when we compare them, we're not going to compare them to someone of their same chronological age who wasn't premature. We're going to work it downwards and compare them to someone who's actually younger. And we expect that to eventually stabilize and work itself out. But we do have to make that allowance.
in talking about all the support and all the things that go on, and you were telling us that you get a little involved in the fundraising, and this is through the Innova Foundation.
Correct.
And they have they give people the opportunity to direct their funds to specific projects.
Absolutely. Which we direct to the NICU.
Right, we direct to the NICU, and that's a great thing. And I think probably those of us in pediatrics and who care about babies don't really care about contributing money to the rest of that hospital, but they seem to abscond with it whenever you do in one way or another. And you work with the March of Dimes, and that's something, had you worked on with them before you delivered a premature baby?
I had not. I years ago had been a social worker in a NICU, so you can imagine what it felt like to be the patient, laying there and having the social worker come in and give me an assessment. And then I was home with the kids for years, and then I really saw this opportunity to work with the March of Dimes. They were opening a new site for the NICU Family Support Program at Fairfax, and it just was my dream job. You know, I'm never leaving, because it's a passion for me, it's a perfect match, because I just feel so strongly that families want information, families deserve support, they deserve family-centered care, and the hospital is just really behind that philosophy, and I'm just there to bring the whole March of Dimes to that. There's lots of information, there's lots of materials. Anne's even on our advisory committee.
And I know that there is an excellent website, and it's www.marchofdimes.org.com. Okay, and we have some other websites. I'm hoping that Sid can flash them up on the screen as we talk. But it needs everyone's support, and it's a great testimonial to hear the stories of these people and their kids, and to have some here. In particular, our record-breaking 13-ouncer who's here and smiling with us, and that's a fantastic thing. So I really thank you all. You're courageous in your experience with your babies, and courageous to come here and talk about them. And I thank you. I thank you all. And I thank you for watching, and until the next time, I'm Dr. Russell Libby, looking out for your health. So that's it. We're through. But we're going to sit here for a couple minutes. You can scream and yell and applause for yourself. Yeah, that's true. You did a great job. And time goes really fast when we do this. We'll stay here for a minute. Sometimes he needs just some audience shots to sort of transition. There was like a shot where my bald head in the back showed up too brightly. You see, you've mastered it. It's easy for you. If I had a handsome head like yours.